as we were talking about areas of interest and discussion for this group, Leanne and I thought that Prop 1 would be a particularly excellent topic for everyone's awareness and information. And I think there's a lot of change happening, some of which will be very visible in the community. Because there's actually funding to build infrastructure in addition to changes happening around how Mental Health Services Act funding is utilized. And so I'm really, really grateful for Contra Costa Behavioral Health to join us this afternoon and really give us an overview of Proposition 1, which the voters passed in March of 2024, if you can think back that far to the election, that particular election. I just want to thank you. And Marie, I am going to ask you to introduce yourself. And then I know you have a team that is joining you. And if you could introduce your team, that would be great. And then when you're ready, Meg will pull up the slides. And I don't know if we asked you this before, but if people want the slides, can we give them out afterward? Yeah.
Yeah, I think that's fine.
Okay, terrific. So take notes, but you don't have to scribble everything down. So Marie, please introduce yourself and your team. That would be terrific.
Great. Thank you very much for having us. I'm Marie Scannell. I'm Program Chief for the Behavioral Health Forensic Mental Health Services here in Contra Costa. And I will pass it to Adam to introduce yourself.
Yeah, thank you everyone for having us. My name is Adam Down. I'm a program manager overseeing Housing and Support Services Administration here in Contra Costa Behavioral Health. And Fatima?
Good afternoon, everyone. My name is Fatima Matasol. I'm Chief of Alcohol and Drug Programs with Behavioral Health. Thanks for having us.
Hi, and my name is Georg Leunecker. I'm the Program Chief for Children's Mental Health Services at Contra Costa Behavioral Health. It's good to be here.
Hey, if we can get the PowerPoint, we'll start with the presentation.
All right, can you all see that?
Yes.
Great, then just tell me when to advance and I'll click through them.
Please go to the next slide. Okay, we're going to go ahead and get us started. Behavioral health transformation goals: improve access to care, increase accountability and transparency for publicly funded county-administered behavioral health services, and expand capacity of behavioral health facilities across California. Next slide. This initiative also has, and actually the behavioral health plan has statewide behavioral health goals. There are goals to improve and goals to reduce. Goals to improve are improving the care experience of our clients, access to care, improving access to care, improving prevention and treatment of co-occurring physical health conditions, improving quality of life, social connection, engagement in schools, and engagement in work. Goals to reduce include suicides, in reducing overdoses for opioids, reducing untreated behavioral health conditions, reducing the number of institutionalizations, reducing the rate of homelessness, reducing the number of admissions or justice involvement, and reducing the rate of removal of children from home. Next slide. And so the Behavioral Health Services Act, a little bit about the history and context. As Rebecca was referring to, in November 2004, Proposition 63, or the Mental Health Services Act, passed. California voters passed Proposition 63, or the Mental Health Services Act, MHSA, as everybody knows in the community. It transformed California's public health system into a more person-centered, prevention-oriented system with direct involvement and input from clients, parents, families, and diverse communities. In March 2024, most recent Proposition 1, or Behavioral Health Services Act, was passed by California voters, which transforms the MHSA, or the Mental Health Services Act, into what we now know as the Behavioral Health Services Act, or BHSA. BHSA expands services for individuals which may have mental health and/or substance use disorder challenges. The BHSA is part of the behavioral health transformation, with most changes scheduled to go into effect July 1st, 2026. Next slide, please. I'd like to introduce Carol.
Oh, actually, Marie.
I think I'm taking this one. Yeah. So thank you, Fatima. So you'll see here a change in the funding from the MHSA to BHSA. On the left of the screen, MHSA had the funding broken down into more buckets of funding. We'll be going forward on the right with BHSA with 3 main buckets. So we'll have 30% of the funding going towards housing, 35% going towards full service partnerships, and I'll say a little bit more about them a couple slides from now, and then 35% to behavioral health services and supports. And that 35% includes behavioral health services, early intervention, workforce education and training, capital facilities, and innovative pilots and projects. Okay, next slide. So priority populations under the new BHSA include both eligible adults and older adults, as well as children and youth, and specifically focusing on, in both groups, anyone chronically homeless or experiencing homelessness or at risk of homelessness, as well as either adults being at risk or at risk of being in the justice system, as well as juveniles being in or at risk of the juvenile justice system. Also, for both adults and children, those re-entering the community from prison or jail or from a youth correctional facility, and for both groups being at risk of institutionalization. In addition, for adults, those who are at risk of conservatorship, and for children and youth, those at risk of being in the child welfare system or currently in the child welfare system. Okay, next slide. So one of the big changes in the adult system of care will be having stepped down 3 levels of care. So starting with the most intensive level, which is level 2, assertive community treatment, or the ACT model, which is an evidence-based practice for providing behavioral health services to those adults and older adults with the highest level of need. And this model has a multidisciplinary team that provides multiple face-to-face contacts a week for individuals. So it's the highest level of outpatient services for someone struggling with severe mental health and or with addiction problems as well, and co-occurring. And so all of the ACT teams will be SUD capable. And so it's a good step towards integrating our mental health and our SUD services even more than they currently are. Then as somebody stabilizes on the ACT teams, they'll step down to what's called FSP, Intensive Case Management, or ICM. Similarly, it's a multidisciplinary team. It's for individuals who have stabilized or did not get to the point of needing level 2. It also includes multiple contacts weekly, so that somebody is able to stay in the community and develop a stable, meaningful life for themselves. And then they could also step down further to outpatient mental health and or SUD services. Next slide. I'll pass it on to Adam.
Yeah, I think this one's me. One of the big buckets, again, was the 35% FSP, 35% community services and supports, and 30% will go into housing. behavioral health for a long time has felt as contributed to housing in many ways. What I think really changes under BHSA is we move more from the left side of this chart where you're looking at it to the right side for the housing dollars that are funded under BHSA. So again, we've for a long time thought we've provided housing, but this was really kind of as a continuum of someone's treatment. Folks would be getting better, or let me just take a very linear example. Someone had an acute episode and it was 5150. Maybe they spent some time at 4C at the county hospital. Maybe they were transitioned to a subacute setting like a mental health rehabilitation center, and maybe they spent some time in an enhanced board and care where we pay a patch on top of that. All of that was sort of how behavioral health had traditionally viewed housing. While we did have programs kind of on this right side in the orange there, we do have a master lease program and we do some of this stuff. BHSA is really opening the doors to enhanced opportunities towards creating and enhancing either existing programs or developing more to provide housing for those who are most vulnerable and also suffering from serious behavioral health conditions. Next slide.
And that will be me. So I'll talk about some of the new mandates that will come to the children's system of care, having to do with introduction of evidence-based practices for the priority populations that were named before. So high fidelity wraparound will be the full service partner program. Marie earlier spoke about FSPs or full service partner programs in the adult system of care. In the children's system of care, the default full service partner program is high fidelity wraparound. California has done wraparound, or many counties have done wraparound for a very long time, following California standards, but with this introduction of high fidelity wraparound, California is adjusting its standards to meet the high fidelity wraparound standards of the National Wraparound Institute. Again, we'll make this available to kids qualifying for full service partner program, kids and families. Then coordinated specialty care for early intervention in psychosis. That is also something many counties are doing already, including Contra Costa, but not all counties. So this will be now a mandate as part of the early intervention programs that counties are implementing. And our First Hope program is serving two subpopulations. One population with who show signs of clinical high risk of developing a psychosis, or individuals who already had the first break, but the first break is not longer than a year ago. So catching clients early and providing a robust, a very comprehensive set of services to prevent the deterioration of functioning and help to a full recovery. Then functional family therapy and multisystemic therapy are two forms of very structured short-term family therapy interventions that are aimed at young people, especially adolescents, to prevent them from becoming involved in either the child welfare system or the juvenile justice system. Functional family therapy is a form of therapy that very much includes the client, works with the whole family system. The family system is the client. And multisystemic therapy is probably more aimed at kids at risk of becoming just as involved. that is a treatment form that works specifically with the caregivers and other supportive systems that may be involved with the child or the family, like perhaps child welfare or special education system or other systems that may be involved to help provide like a container, a sound structure for perhaps a treatment resistant or treatment reluctant to engage adolescent. And then finally, parent-child interactive therapy is a form of therapy aimed at helping families with very young children, ages 2 or 3 up to 7, 8, where the therapist provides a lot of coaching and direct sort of a guidance on how the parent, the caregiver, should interact with the child to form healthy bonds and provide the right supportive structure to achieve affect control. Next slide, please. And so within this Behavioral Health Services Act guidelines, we have to develop, or counties have to develop, an integrated plan similar to the MHSA plan. The MHSA plan, as you remember, has been done every 3 years with 1-year updates. That is now similar with BHSA, with a difference that the plan has to account for all funding sources. So it is not limited to just services funded through BHSA dollars, the millionaire's tax, but also includes other funding sources, realignment, Medi-Cal, other funding sources, grants, and so on. And it obligates counties to engage in a robust community planning process to develop that plan. And I will hand it over to Fatima.
Thank you, Gerald. The integrated plan, as we call it, requires counties to report plan activities and projected expenditures for all county behavioral plan services, which means not only all the funding revenue that mental health has, but also it includes substance use. So all the funding has to be reported. And also, I have to say that as part of this robust community program, counties were required to include 30 different stakeholders, all of whom required. Next slide, please. And so our community planning, our community engagement process started in early February, February 18 to be exact. And it started with an internal planning group that was comprised by people working in the community, boots on the ground type of people. Also a couple of clinicians that work with a diverse community in Contra Costa County, but really the forte was those folks that are in the field in different communities throughout our county. What you have in front of you is the timeline that we created for the community to inform the community the steps that we were taking. We have a different tracking sheet which breaks down every single step from 1 to 2. And there's a number of steps in between. But this is a more visual description for the community so that you have a sense of everything that we have to do between establishing that planning group, which was a requirement, all the way to the community engagement, to the analysis of the information gathered through the community, to the point where we have to have a 30-day public comment. We also have to incorporate the newly created behavioral health board, which combined or actually it dissolved the Mental Health Commission and it dissolved the Alcohol and Other Drugs Advisory Board. making it into a single behavioral health board. So this plan has to go to the behavioral health board, but in addition to, it has to be approved by the CAO of the county. And last but not least, it has to go to the county board of supervisors for approval. There will be a hearing, a 30-day public hearing process before it's approved by the county board of supervisors. So we're a long way. As you can see, we are barely at step 08, where we have analyzed all the information that we gather from the community. We've collected a lot of data, existing and not available data necessarily. So for example, we're looking at overdoses. The data and the feedback has focused on the goals, on those bold goals that I explained early on in the presentation. So we are in the stage of incorporating all that feedback, and we're starting to, we're in the baby steps, initial steps of writing the narrative of the plan. But it is a huge endeavor. Next step, please. Next slide. So the community voices. So as you can imagine, we went through a huge community engagement throughout the county. Can I see the next slide, please? And what we did is we organized all the data through themes in order to analyze the information given to us by the community. We clustered them or categorized them under access to care, quality and effectiveness of services, housing and support services, and lastly, we wanted to get some insights and suggestions from the community, and we wanted to validate that by incorporating all of these information into the plan when it's developed. Next slide, please. And so a little bit of a preliminary analysis and takeaways from very broad strokes. The community really appreciated the opportunity to be engaged. They express significant system navigation and awareness challenges, more specifically about the services. They acknowledge that the services are there, but that it's not easy to navigate, and most people don't know that they exist. Also, they stated that equitable access to care requires special considerations for diverse populations. So our services are not for one size fits all. We have to take into consideration the cultural diversity of our community. Next slide, please. And so just to share with you, we've conducted 61 different type of events from April through July 2025. This included 37 community conversations, which are smaller groups, very intimate, to allow people to share their experiences in the system, awareness about the system, the type of services that they would like to have. And it was a kind of like a guided conversation. We also had 10 different stakeholder focus sessions. Those sessions were more specific with existing teams that there may be in the county. For example, teams that already exist to support the needs of AB 109, which is justice-involved populations. We went to the Older Adults Coalition because one of the populations of focus is older adults as well. We also held a stakeholder focus with a group of providers that supports the need of transition age youth involved within the justice system. We also went and worked with our homeless or H3 program with all the different professionals that are there, and also with the Council of Homelessness. We ran a more stakeholder focus session. The reason was they, as professionals, these are multidisciplinary teams in many cases that touch many of our clients, both mental health and substance use. And we wanted to understand their experiences as they interface with us and as they interface with their clients. We also conducted 7 town hall forums. These town hall forums were a little bit more opened that included a presentation a little bit longer than the one we're doing today, with an opportunity for the large group to participate in small breakout sessions where there was a facilitated discussion about some of the goals from the state and the services that are provided or expected to be provided. Some of these town hall meetings included our community-based organizations that have a contract with behavioral health, and also members of the community. The town hall forums were a mixture of populations. We also ran one town hall forum meeting in Spanish. We also make sure that we had incorporated one of these sessions, community conversations with kids at juvenile hall. And we also conducted a session with clients at the detention facility in West County. So, clients in jail, basically, that are recipient of our services when they're inside or outside the detention facility. And lastly, we conducted 7 key informant interviews. These were more specific to some of the individuals required in the stakeholder list who may not have had the time or the bandwidth to attend any of our town hall forum meetings, and for whom we had specific questions to ask. These may have included the public health director in our system, and the managed care plan. In our case, is Contra Costa Health plan, and the reason is this plan, this integrated behavioral health plan, must be integrated or at some point, but done in collaboration with the managed care plan and also with the public health plan. Public health is also required to have a community health assessment, which should also ideally, when they complete it, some aspects around behavioral health. So the state is certainly looking for a lot more integration to look at more holistic health, as you can see. And we also completed 741 surveys. This is a lot of information, lots of information. Clients in the jail participated with surveys. The surveys were both in paper and electronic, and the surveys had been translated in Spanish as well. Next slide, please. And this is just a sample of the many organizations that we've, this slide 16 and 17 is an illustration of the many organizations that we touched through this community engagement process. And we make sure that we capture all the required stakeholders by category. We may have omitted a couple, but for the most part, it's a highly comprehensive list across different domains. Next slide, please. And this is the same thing. We also wanted to make sure that we capture some of the populations and some of the disciplines that were required. The community conversation with veterans was actually really, really super important. And also the session we conducted with transgender kids who were not transition age kids, but under 18. And let's see, and then, the Scotts Valley Tribal was a very important conversation because this is represented by members of tribes, local tribes here in the county. Let's see, next slide.
Okay, and I'll give a little bit of a taste of what the input was according to the different domains. As you remember, access to care, quality and effectiveness of services, housing and support services, and community insights and suggestions were the 4 domains that we bucketed the feedback into. And so with regard to access to care, what we often heard was, well, I don't know where to start, and simplifying the mental health system and providing clear guidance step by step in multiple languages would help people navigate services more easily. So next slide, please. With regard to opportunities for improved outreach, we heard that how important it is to have trusted sources and messaging about mental health, how crucial that is. It was said that my community sees mental health as a taboo and is often dismissed as a personal behavior choice rather than as a health issue. So there's a lot more education and outreach necessary. And that we need to make people comfortable and make them feel welcome to ask for help. Next one, please. And with regard to effective approaches, these are all broken down into subdomains. I just, we picked a few to give a taste. We heard that how important it is to have compassion-led, fully funded supportive programs where the length of stay is tailored to the individual rather than a standardized template. And with the next one, I believe I hand it over to Adam. I think this one is still me. So we heard that with regard to equitable access to care, that vocational services are needed to be more accessible along with other life skills programs, that we need funding for older adult services since they're being cut by federal government, and the need for youth programs were highlighted, especially with regard to LGBTQIA programs. And now I'm handing it over to Adam. Next one.
Yeah. So I think housing and support services is that it came out as a theme is interesting, especially when kind of the other two big buckets were things like access to care and effectiveness of care. But I think when you take a look into what housing and sports services came up with, is the themes still applied very acutely. So it was a lot about a lack of awareness. How do we access these services? And can we do a better job on supporting people in housing? Highlighting just this lack of awareness, I hate this quote really, I think really just kind of gets to the point that I'm homeless myself and desperately seeking housing. When you find out, let me know. Where are we missing this message and how are we not serving this person? So next slide. Am I continuing here?
Yes, you're continuing.
Okay. So the additional insights and feedback. There really needs to be better data sharing and coordination among providers, something we heard time and again. The importance of prevention and early intervention services, tailored services to diverse populations, funding reduction concerns. We can probably talk about that a little more in a Q&A. And providers should be trained at same level as county staff. I add a little context to that. Behavioral health contracts out a substantial portion of our work, and sometimes there's a difference in a perception of the level of training that county staff are providing. So it goes to the workforce education and training, and recommendations for resource allocations. Just to highlight a couple of quotes regarding better data sharing, coordination. There's a disconnect in sharing information. Hospital programs, county departments, MET teams, clinicians in the field, doctors, nurses, first responders. We need urgent, quick flow of information among entities. And stakeholders highlighted the lack of data integration within departments and counties, which hampers effective communication and service delivery. Next slide. Okay.
That is it.
Awesome. Well, I think this is where I pop in here and we can begin the Q&A. So first of all, thank you so much, Contra Costa County Behavioral Health team, for being with us today and giving us such an insightful presentation on the progress of Prop 1 implementation. Just to keep things organized, because we do have, about 15 minutes, a pretty much good amount of time for Q&A. Feel free to use, the raise hand feature on Zoom, or just drop a question in the chat. I see we have a few of them in the chat, so I'll be reading those out and get those answers. We want to make sure that everyone has a chance to participate, so feel free to keep your questions concise and on topic. And if we don't get to your question, we'll make sure to do our best and follow up. So unless anyone has any burning questions off the top of head right now, I'm going to go ahead and read the first question that I saw pop up from Debbie. I believe she was referencing the community working plan chart about, curious to know how much feedback you got relating to aging and disability needs, given the cutting of older adults from Prop 63.
And then they had a slide following that had choice and aging on it. And so I had to do the little monkey covering its eyes because evidently we were involved in that. And I'm just not remembering it because I'm the human who would do that probably. But yeah, I am curious just because that was a population that was totally carved out. And hi, Fatima.
Hello, Debbie. Hello. Debbie and I became really, really close during COVID. That's actually how we became to know each other. So we did a presentation to the older adult coalitions through our older adult programs in mental health. And somebody was representing choice in aging in that coalition. So we thought we would list that person because she did have a voice. And I happened to be in that presentation. We did a stakeholder focus presentation. And I learned so much about some of the challenges experienced by older adults that I hadn't even thought about. We have this phenomenal transportation benefit through CCHP. Well, that doesn't work for older adults. It's a major barrier. It increases a lot of those symptoms in mental health. It exacerbates a lot of the symptoms that have led them to receive services through older adults in the first place. Also, technology is not something, it's not a tool that it works for them. And we think, for some other populations, that's what they want. Transition age youth, they don't want any paper. They want all technology. They want text. They want social media. Well, that's quite the opposite with older adults. So Debbie, there was a representative from Choice of Aging in that large group, and that's why they were listed.
Okay, I think we have a second question here in the chat from Douglas. Is applied behavior analysis, is it included on those services?
So I did try to answer in the chat that ABA services is a benefit that is managed through our partners on the managed care plan. So CCHP or Kaiser, they can refer to ABA. And our managed care partners on the managed care plan, they have contracts with ABA providers.
Okay, thank you, Gerald. I just saw your reply right now in the chat. Okay, let's see. I think that's it. I know, Gigi, you had a comment in the chat. I don't know if you want to elaborate a little bit on that, or if you'd just like me to read it.
I don't take it lightly when I give up a weekend. And so we did have you all come out to NAMI Contra Costa to work with, since this county only identifies 2 threshold languages in the behavioral health space, English and Spanish, which is shocking to me, coming from Alameda County. You don't recognize Chinese or Mandarin, but we know at NAMI CC, we serve a large number of individuals who are non-English speakers, and especially their families. And you came out and we had such a great day with the over 25 individuals speaking to you. I didn't see it on the chart, so it made me wonder if it's going to be embraced in the future work you're going to do.
It should be embraced, Gigi, and thank you. Gigi facilitated this session facilitated the space for me to go and present on a Saturday morning. And this was right at the time when her staff and volunteers all go on vacation. But the moment I entered that room, there was so much warmth and welcoming. There was a lot of food, delicious food that participants were going to have later after the presentation. The room was packed of Asian Pacific Islanders. And for each of these sessions, there have been words or phrases that have resonated in my head. In this particular one, there were a couple of things. One was the county needs to have situational awareness, that there's more Asian Pacific Islanders now that have migrated from San Francisco to the East Bay, to here is Contra Costa County because of housing issues. And it's not necessarily the affluent Asian Pacific Islanders. There's a lot of Medi-Cal Asian Pacific Islander population that has migrated to our county. A lot of them express isolation. They express, they don't know about resources. And because of the many languages, it makes it particularly challenging to them to access those services. I also learned a lot of Asian Pacific Islanders, and I truly apologize and felt so humble at learning this for the first time, but I did not know that a lot of Asian Pacific Islanders work at casinos. The outreach that we do is not necessarily in casinos. And people working in casinos are working under a very stressful environment. So to me, all these community conversations and presentations have been really enlightening, not of things that I knew already, that we knew already, but new things. So if they weren't added, Gigi, my apologies, they will be included and they should be included. And we will be embracing, every, comment and input that we receive throughout the multiple populations. Thank you.
I see a raised hand here. Go ahead, James.
Thank you. Great presentation. And I'm just a layperson in this area, but very, very timely. Yesterday, colleagues and I were actually at San Quentin, and we're getting more engaged in financial literacy program over there. And several of the inmates, if intervention had only occurred much earlier, and that's a common theme. So, huge kudos and thank you for what you're doing with these dollars. And then this is more of a naive question. A couple of days ago, we were chatting with one of our clients and down in Santa Cruz, and he's involved with a nonprofit called Housing Matters. So do you leverage your dollars with nonprofits that are kind of sort of in a similar, they have a similar mission? Just a question. And again, thanks for what you're doing.
If we're talking about housing, I'll go ahead and jump in about that. We do some, and we need to do more, I think is the answer to that, Mr. Brandt. As we look to expand the types of services that we're providing and really get into more of that supportive housing space and these highly supported interim models, we will be needing to work additionally with other partners, both as direct contractors, but as also developers, and really bringing resources in line. I think there's a lot of flexibility within BHSA to really do some exciting things in that area about, partnering with, developers to bring different sources on through operating subsidies, through rental subsidies, voucher-like programs, things like that. So I think we're just in the beginning stages of sorting out what that'll look like. But we're excited to do more of it.
Thank you.
Thank you, Adam. We have time for a few more questions. I saw Gigi's hand raised first, and then we'll go to Rebecca.
Yeah, because I had a two-part. So I spoke about the AAPI because in this county, we don't have any direct services for the Asian American Pacific Islanders. So I'm telling people, do you have a relative in Alameda County where they have much more robust services? That never feels good that you would have a fail-first system where people have to get only get their services through psych emergency services. So that was one. And then the other part of that was addressing the needs of African Americans who are so often criminalized when they live with mental illness, especially our youth population, where we have it documented that 60% of the young people in our juvenile justice live with a diagnosed mental illness. Unless that's changed, I don't think it has. And so trying to be more preventative. So I saw Gerald, I saw you use evidence-based practice. Is there any room for community-defined practices? Practices that are proven to be successful without the dollar spent to lift them up to EBPs?
So we do have some programs that are funded through Measure-X that contain or pursue community-defined evidence-based practices. So, so I limited myself in my presentation to the services that are mandated to implement, and will certainly help the population that you were referring to as well. And we do have a pretty robust behavioral health program, both mental health and substance use services in children detention and following youth stepping down from detention back into the community, where we provide those services and have contracted with providers to pursue more preventive community-defined evidence practices.
Thank you.
Thank you.
Do you want me to go, Leanne?
Yeah, you're next.
I was just sort of thinking in my head about the fact that, through HR 1, we're going to see a lot of individuals lose their Medi-Cal coverage. And I honestly, this might be a stupid question because I honestly don't know, but for all the services that you're offering and talking about through this behavioral health plan, do you have to have Medi-Cal? And if you lose your Medi-Cal coverage, how will the county be serving people who still need these services? That's my first question. And then the second one is, you didn't really touch much on the fact there's the whole bond initiative associated with Prop 1, and there's actually facilities being built in Contra Costa. And that could maybe you could just, as a follow-up, just send us some information about what's going on there, because I know that the county has received some infrastructure funds, which I think are very exciting. So
I can take that really quick, that piece. I worked with the team that put together the BCHIP applications, Behavioral Health Continuum Infrastructure program. And Contra Costa was awarded $98 million under the bond BCHIP. Around the county itself was, and then there were a couple private organizations that also received dollars from that. So with those funds, we intend to develop more on the treatment care continuum side things. So 3 social rehab facilities, two social rehab facilities were funded. A mental health rehabilitation center, 16-bed out in East County, 1 social rehabilitation center, which is adult residential treatment, it's a Medi-Cal billable service. There was another social rehab in Central County that was funded. And then a very exciting project that will co-locate withdrawal management, sobering center services, and then a mental health crisis triage out in Pittsburgh. So all of those are online. We're in the planning stages of that, of actually building these buildings. Those funds need to be expended by June 30th, 2030. So we have a little bit of time, and these are big construction projects, which take a minute, but we're very, very excited about those. And this is on top of an $18.6 million award to build our first in-county mental health rehabilitation center out in West County, which we received under the first rounds of BCHIP, so round 5 in the last section, which is actually a little different than the Prop 1 piece. So sorry, I didn't mean to cut you off, but I could definitely speak to that one very quickly.
Does anyone want to tackle the Medi-Cal question? Do you have to have Medi-Cal to get services under this plan?
So under BHSA, I'm going to go jump in here. It is pretty clear that you do not have to have Medi-Cal throughout most of it. Under BHSA, someone can jump in and correct me on here, but behavioral health is really funded through kind of three large buckets. There's BHSA, there's dedicated funding through realignment dollars, and the third leg of that is the Medi-Cal services. So some of this and those realignment dollars are intended in many ways to serve the uninsured or underinsured from longstanding 91 and 2011. And then BHSA, it does not require that a person be Medi-Cal eligible. It is definitely helpful because we are able to better serve you with the services that are out there. But so for a housing intervention, you do not need to be necessarily Medi-Cal eligible. So hopefully we won't see that. And also just as a general comment, we are very concerned about this loss of Medi-Cal. A lot of our funding is directly from the state of California. So how that backfill, as long as that keeps coming and that's not backfilled or strong-armed in some other way, we feel okay about some of these services moving forward in that regard.
Great. Well, I have a 3 o'clock, so I need to personally jump, but please thank the Marie, Fatima, Gerald, Adam, thank you so much for joining us. That was really interesting. And Molly mentioned, can this group be included in the public comment? And I think that the answer to that is absolutely.
Yeah.
And there'll be multiple ways to do that because obviously, as I saw on that roadmap, there's going to the Board of Supervisors, and even before that, there's going to be some community opportunities. So we will endeavor to keep this group updated so you have that opportunity. And if there's anything else that we heard about today that you're interested in diving into a little deeper, put it on that interest form that Meg sent around, and that will be a clue for Leanne and Meg and I to figure out how to make that happen.
Yeah.
Great. Well, thank you so much. And I got to hop off, but I will look forward to seeing you all at our next meeting on September 25th. Our topic will be the scintillating Office of Healthcare Affordability. And if you don't know what that is, come learn.
That's right. That's right.
Thank you very much for having us.
Yeah.
I also
All
have to
right.
jump
Thanks,
off.
everybody.
Thanks, everyone.
Okay.
Thank you, everyone.
Thank you, Meg.